Hi, are you ready to learn about the ICD-10-CM coding guidelines? In today's video, we'll discuss about the chapter-specific ICD-10-CM guidelines. Hi, in my previous video, we saw about the ICD-10-CM guidelines section 1A convention, and we also covered section 1B general coding guidelines. From today's video, we'll be starting the section 1C chapter specific guidelines. We cannot cover all the chapter specific guidelines in one video because there are around 22 chapter specific guidelines. So we'll be making this as a series. In today's video, we'll begin with the chapter specific guideline, the first chapter, certain infectious and parasitic diseases. Sequences starts from A00 to B99, also includes U07.1, U09.1. Under this chapter specific guidelines, certain infectious and parasitic disease, we again have around 7 subheadings. The first one is the HIV infection, second one infectious agents as a cause of disease classified to other chapters, third is the infections resistant to antibiotics, fourth sepsis, severe sepsis and septic shock infections resistant to antibiotics. So we'll be covering these 4 in today's chapter. And in my next video, we'll cover the remaining pending 3, that is the MRSA conditions, then Zika virus infections and coronavirus infections. So chapter 1A, HIV infections. In this HIV infections, the first one is code only confirmed cases. So we should only code the confirmed cases. In the term confirmed, it doesn't mean you should always look for a positive serology or a culture result. Even if there is no positive serology or culture result available confirming the patient is HIV positive or has any HIV related illness, in this scenario, the provider diagnostic statement that the patient is HIV positive itself is enough. And also, if the patient has any HIV related illnesses, then we can consider that the patient is confirmed case. The second one is selection and sequencing of HIV codes. So in this, the first scenario, when the patient is admitted for HIV related condition, like for example, the patient is HIV positive and the patient has conditions related to HIV, all the illnesses are related to the HIV. In this case, the principal diagnosis should be HIV disease, that is B20. And the secondary and the tertiary diagnosis should be all the reported HIV related conditions. The second one in this is patient with HIV disease admitted for unrelated conditions, like the patient is already having established HIV disease, but now the visit to the facility or the doctor is not related to any of the HIV disease. In this case, the principal diagnosis should be unrelated condition and the secondary or the other diagnosis should be B20, that is the HIV disease, and also add all reported HIV related conditions. So pro tip here is, whenever you are choosing ICD-10-CM, always look into the document and choose the principal diagnosis based on the patient's reason for visit. Why the patient came to the facility, like what is the condition and what made the patient come to the doctor's facility. So that should be the principal diagnosis. All other conditions should be the secondary diagnosis. Or there are only few exemptions which I have already discussed in my general coding guidelines, like the obstetric diagnosis. These things I have already discussed in my general coding guidelines, so you can go and watch that if you have not watched yet. I'll put a link in the description below. And the third one on this, whether the patient is newly diagnosed. So if the patient is newly diagnosed, then it is not like it will not interfere with the sequencing. You can sequence as per the doctor's treatment. The next scenario is asymptomatic HIV. What does it mean? The patient is HIV positive or is already known HIV but do not have any symptoms. In that case, you cannot code it as a disease condition B20. In this scenario, we should code Z21, asymptomatic HIV infection status. The next one, you cannot code the Z21 if the patient is already having AIDS or having an HIV disease. That means the patient is already having symptom or disease or all the conditions or all the HIV illness. In this scenario, we cannot code Z21. As long as the patient is asymptomatic with HIV positive, then only you can code Z21. So in the other scenario, if the patient has inconclusive HIV serology, it means the patient has been tested but the result is inconclusive. It is neither positive nor negative. In this scenario, you should be coding R75, inconclusive laboratory evidence of HIV. So in another scenario, if the patient is previously diagnosed with HIV related illness, like the patient has once been diagnosed as HIV related illness, and even after the illness has subsided or if the illness is no more, then also we should code all the subsequent encounters with B20 only. You should not change as asymptomatic HIV infection stage Z21, or you cannot code inconclusive case in this scenario. Once the patient has developed an HIV related illness, then all the encounters for that patient should have B20 only. So the HIV infection in pregnancy, childbirth and puerperium, we should follow this protocol. Like if the patient is pregnant, we'll be coding the principal diagnosis as I already told in my previous video about the general coding guidelines. The pregnancy, the O code should always be sequence principal. So O98.7, which is the HIV disease complicating pregnancy, childbirth and the puerperium should be coded first. And if the patient is having or developed any HIV related illness, we'll be coding B20 as a secondary diagnosis. Or if the patient has not developed any symptoms, she is an asymptomatic HIV patient, then we should code Z21 as the secondary diagnosis. So in the next scenario, encounters for testing for HIV. So if the patient is coming to test for HIV, so if the patient has any signs and symptoms during the encounter for testing for HIV, that sign and symptom should be sequenced first. Then if the patient does not have any symptom, the principal diagnosis will be directly Z11.4, that is encounter for screening for HIV, and then you will add an additional diagnosis Z71.7, which is HIV counseling. So if the patient is symptomatic, you will code the symptoms as the principal diagnosis, then you will code the Z11.4 followed by the Z71.7. If the result is negative, you will be coding Z71.7 only, that is HIV counseling. Like the patient came with a suspicion or just a screening for HIV test, and the patient has been counseled when the result is negative. So if the result is positive, you will follow all the previous guidelines based on the symptom or asymptomatic scenario. The next scenario, the history of HIV managed by medication. The patient's HIV is already managed by the retroviral medication. In this scenario, you will still code B20 HIV disease followed by Z79.899. That is the other long-term current drug therapy. So the patient is on a drug therapy for the HIV management. So that's all about the chapter 1A. HIV infection. So the chapter 1B, infectious agents as the cause of diseases, classified to other chapters. So there are other infection chapters that ranges from B95 to B97. This includes the bacterial and viral infectious agents. All these infections are classified in this chapter. This just gives a note only. There is no particular description or guidelines for this chapter, that is chapter 1B, infectious agents as the cause of disease, classified to other chapters. So whenever those infection agents are mentioned in the doctor's document, like the patient has a streptococcal infection, you can directly go and choose the codes from this range of code series, and there are no other specific guidelines for that. So let's move on to the chapter 1C, infections resistant to antibiotics. So even in this one, infections resistant to antibiotics doesn't have a separate guidelines or protocols to be followed. So if there are like infections resistant to antibiotics, you can go and choose the series from Z16, resistant to antimicrobial drugs, resistant to antimicrobial drugs. Under these series, you can go and choose the diagnosis directly based on the doctor's documentation. So we'll move on to chapter 1D, sepsis, severe sepsis, septic shock infections resistant to antibiotics. So before that, we'll see what is septicemia, sepsis, severe sepsis and septic shock. So what is septicemia? Septicemia is the spread of bacteria and their toxins in the bloodstream. So whenever you have an infection, the bacteria spreads into your bloodstream, and that reaction is called septicemia. So what is sepsis? Sepsis is the body's extreme response to an infection. So whenever you have an infection, that is septicemia in your body, so the immune system in the body immediately produces some response mechanism that tries to eliminate the septicemia, that tries to eliminate the bacteria or whatever organism it might be. Our body's own defense mechanism tries its maximum to eliminate the infection from our body. So in this scenario, what happens? The body sometimes produces extreme response to an infection that becomes sepsis. So this extreme response will affect the patient conditions. For example, when there is an infection, a mild or dust allergy or something, what will happen if the dust enters through the nose? The body's immune self-defense mechanism will automatically respond, and you'll be sneezing. So this sneeze, why the sneeze occurs? This sneeze occurs to eliminate the dust from your nasal path. For some patients, what will happen? A small slightest dust will trigger their asthma. Some patients with small food consumption will trigger their hives. They will get too many rashes. Some people might develop high fever. Some people might develop swelling of the eyes, swelling of the face, and some people will develop swellings in the limbs. These are all the body's defense mechanism trying its level best to eliminate that infection from the body. So when it is extreme, the response is extreme, it results in sepsis. So what is severe sepsis? Sometimes even this sepsis will exceed and it will go and affect the organs. Some organs starts to dysfunction. In this scenario, it is called as severe sepsis. So what is septic shock? Septic shock is severe sepsis with circulatory failure. Suddenly the patient, because of the too much body's defense extreme response mechanism, it might sometimes affect the circulatory system, that is your heart and all your blood vessels. Sometimes it will result in heart failure or sudden cardiac arrest like that. So if it's involving the circulatory failure or cardiac arrest like that, then it is called as septic shock. So we saw what is septicemia, sepsis, severe sepsis, and septic shock. So we'll see about the coding of sepsis and severe sepsis. So coding of sepsis, we will be assigning code for underlying systemic infection. So which systemic infection is, like which system there is infection, you will be coding that one. Or you can code A41.9, that is sepsis unspecified organism, if the organism is not specified. And under coding of sepsis, if there is a negative or inconclusive blood culture in sepsis, you cannot code it as sepsis, and also you cannot consider urosepsis as sepsis because it's not a specific term. In this scenario, you should query the provider for clarification. And also when there is a sepsis with organ dysfunction, you cannot code that as sepsis because there is an organ dysfunction. This should be following the guidelines of severe sepsis. So there is an acute organ dysfunction, but that is not clearly associated with sepsis. Like the doctor does not mention that this acute organ dysfunction is a result of sepsis. In this scenario, we cannot code. Maybe this acute organ dysfunction might be the result of some other disease condition unrelated to sepsis. So in this scenario, we should query the provider. So in these scenarios, we cannot code it as confirmed sepsis. So in the next one in this is the coding of severe sepsis. So like the same with sepsis, you will be assigning the code for underlying systemic infection if there is a direct diagnosis for that. Otherwise, you will be coding A41.9, sepsis unspecified organism, if the organism is not specified. In addition to that, you will be coding R65.2, severe sepsis, and also we will be coding the associated acute organ dysfunction, because severe sepsis means there is an organ dysfunction involved. So coding of septic shock, you'll be assigning code for underlying systemic infection, and then you'll be adding code R65.21, which is severe sepsis with septic shock, or you can code T81.12 if this septic shock is after a procedure, after a procedural thing, then you'll be coding T81.12 post-procedural septic shock after a surgery, minor or major things. Where after that, if there is a septic shock, then you'll be coding T81.12, not R65.21. Then you'll be adding the associated acute organ dysfunction. So the next one is the sequencing of severe sepsis. In this we have two scenarios. If this severe sepsis is present on admission, where the patient is being admitted, if this severe sepsis is present, then you will code the severe sepsis R65.2 or any underlying systemic infection as the principal diagnosis, and then followed by the other diagnosis. If it is not present on admission, like when the patient is being admitted, at that time of the admission, the severe sepsis is not present in the patient, then we should be assigning this as the secondary diagnosis. So always, as I told before, the reason for the visit should be the principal diagnosis. So the next scenario is sepsis or severe sepsis with a localized infection. Like for example, the patient has a sepsis or severe sepsis. At the same time, the patient has some other localized infection unrelated to the sepsis or severe sepsis. In this scenario, we should code the underlying systemic infection as principal, and then secondary will be the R65.2 severe sepsis, and followed by the localized infection. Here, what are we following? Both the conditions are present at the time of visit. We will be considering the severity scenario. So this is called as the severity scenario. So both the conditions are present at the time of visit. You will be choosing the principal diagnosis based on the severity. So the next scenario here is sepsis or severe sepsis with a localized infection. But this localized infection is present on the admission time. Later, the patient develops sepsis or severe sepsis in the hospital. In this scenario, you will be coding the principal diagnosis as localized infection. Now you know the drill, right? What concept the coding is going on? Yes. What is the reason for admission? Should be the principal diagnosis. So secondary will be, you can code any underlying systemic infection, and then followed by the R65.2 if the patient has a severe sepsis. So the next one is sepsis due to post-procedural infection. So when there is an sepsis because of a procedure or a surgery, as a result of the post-procedural infection, the patient developed a sepsis, there should always be a documentation that supports that this sepsis is because of this procedural infection. So there should be a documentation to support that the sepsis is due to this procedure. Otherwise, we cannot relate together when it appears in the documentation together. We cannot assume that this is because of this. There should always be a clear documentation mentioning that there is a relationship between this infection and the procedure. So the next one, in the sepsis due to a post-procedural infection, we'll see about the sequencing in coding. So if this is a general procedure, and because of a general procedure a sepsis has occurred, the principal diagnosis you should choose from the T81.40 to T81.43 series, followed by the secondary diagnosis from T81.44. So the T81.4 is the infection following a procedure series. So secondary diagnosis, you will be coding T81.44, which is sepsis following a procedure, followed by the R65.2 severe sepsis if there is a severe sepsis, along with the acute organ dysfunction. This sequence of diagnosis you will be coding for sepsis that has occurred due to general procedures. So if the procedure is an obstetric procedure, as I already told, all the obstetric cases have a different kind of sequencing. There will always be in O series. So you will be coding principal as O86.00 to O86.03. That is the infection of the obstetric surgical wound, followed by the O86.04, and later by the R65.2 if there is a severe sepsis, along with the acute organ dysfunction. So this is how you should code and sequence the sepsis due to a post-procedural infection. So the next scenario under this post-procedural infection sepsis is if the infection is after infusion, transfusion, therapeutic injection, you will be coding T80.2, which is infection following infusion, transfusions and therapeutic injection as the principal diagnosis, and later you will also specify what kind of infection it has happened. That is will be the secondary diagnosis. So if there is a severe sepsis, it will be followed by R65.2 with an acute organ dysfunction. So if this infection is after immunization, so sometimes the patient is going for immunization, after that there is infection and the sepsis has developed. In this scenario, the principal diagnosis should be T88.0 series, which is the infection following immunization series. Then secondary will be the specific infection, like what kind of infection it has occurred, followed by the severe sepsis, if there is severe sepsis, R65.2, along with the acute organ dysfunction. So under the sepsis due to post-procedural infection, the C point, post-procedural infection and post-procedural septic shock. So if there is a septic shock, in this scenario you will follow all the sepsis guidelines by coding those diagnosis principle, and at the last you will be adding this T81.12 as post-procedural septic shock with acute organ dysfunction. So you will add an extra septic shock, post-procedural septic shock diagnosis to the previous guideline. So the sixth point here under the sepsis, severe sepsis and septic shock infection is sepsis and severe sepsis associated with a non-infectious process or condition. So in this scenario, so the sepsis or severe sepsis has occurred not because of an infection. It might be because of some other process or condition that is a non-infectious process, like trauma, burn, etc. Like the patient might have met with an accident or a burn injury that might have resulted in sepsis or severe sepsis. So there is a diagnosis R65.1. Please do not choose that diagnosis because the diagnosis states SIRS of non-infectious origin, systemic inflammatory response syndrome of non-infectious origin. We should not code that because this is non-infectious. We cannot go and choose that one. Instead, we should consider the principal diagnosis based on the reason for visit. What is the main reason for visit? Is it the treatment is pertaining to the injury or the burn? Then we'll be coding that injury, trauma, burn as a principal diagnosis, followed by the sepsis and severe sepsis codes. Or if the treatment is pertaining to the sepsis or severe sepsis, you will be coding that as the principal. So if the patient is coming for trauma or burn, you will code that one or the sepsis. And then you will be adding, in severe sepsis cases, you will be adding R65.2 along with an acute organ dysfunction. Seventh one, sepsis and septic shock complicating abortion, pregnancy, childbirth and puerperium. For this, there is a detailed explanation in the chapter 15 guidelines. And for the newborn sepsis, that is the sepsis in the newborn babies, we will be following the chapter 16 guidelines. They take the precedence. So that's all for today's video. In this video, we covered about the ICD-10-CM chapter specific guidelines. Under that, we saw the chapter 1, certain infectious and parasitic disease. Under that, we saw HIV infections, and the B and C are of not much of significance. We saw the D, sepsis, severe sepsis and septic shock infections resistant to antibiotics. So majorly we focused on HIV infections and sepsis, severe sepsis and septic shock infections resistant to antibiotics in today's video. So in my next video, we'll be seeing about the remaining three, that is the MRSA conditions, Zika virus infections and coronavirus infections. Actually, I don't want to combine all the guidelines together because understanding the guidelines is a bit difficult because it's very vague. It's just numbers and some guidelines, right? So it will be really vague and it will be really dry if I'm trying to teach you all in one go. It will be of no use. So that's why I'm just breaking up these videos into several series which will be beneficial for you. So if you found this video to be useful and if you have learned something new in this video, please hit the like button. And that will really mean a lot to me. And if you're new to this channel, please subscribe and hit the notification icon so you'll not miss any of my future guidelines or general coding guideline related video. This is Surya Johnson, your medical coding guide.